recording at all. Start recording. And Katie, I got you. You get credit. We'll be in here. Okay. So most people will have some degree of GI distress. If that GI distress would prevent them from taking the medication, then they should try to take it with food. So that's always the directions. Always we want people to increase their fluid intake and to not drink alcohol. Certain antibiotics actually have a reaction with alcohol where the person will get sick, but anyone who has an illness should increase their fluid intake and not drink alcohol, just because it's common to get dehydrated when you're sick. You should take the whole prescription as prescribed, because that again increases the risk of antibiotic resistance if you take a prescription and stop in the middle of the course, because you're more likely to have maybe one or two bacteria left behind, or you're more likely to have issues with resistance. And then the last two are when to call the provider again. So the patient starts antibiotics. They're not going to feel better immediately, but they should no longer have any fevers after 48 hours of taking the medication. And sometimes this is, if you were, if you work in the hospital, a fever is defined as a temperature of 101.5 or greater. In the outpatient setting, the fever is over 100. So it'll be obvious on the exam which one we're going for. It'll be an obvious fever, just so you're aware of that. And then call if symptoms persist after completion. So you finish the antibiotics, you should no longer have the symptoms of the infection anymore. They should call, maybe they need to be on the treatment for a longer period of time, or maybe it's not the right thing.
Could you repeat the temperatures and which one was hospital, which one was home?
Sure. So in the hospital, a fever is 101.5. That's usually what the standing orders say. At home, most providers will say that 100 or 100.5 constitutes a fever. And I believe in your textbook it says 100. That would count if you were going to call again, because you still had that temperature after 48 hours. But for my test, it'll be an obvious fever. So there won't be any kind of question like, well, I'm in the hospital, blah, blah, blah. So there won't be an issue with that. Pediatrics, yeah. So it's usually lower as an outpatient, because as an inpatient, you have time to respond to things, and usually there's some degree of infection that's expected, or some degree of temperature expected from atelectasis, but as an outpatient, it's a little stricter. And then now we have the common side effects of all antibiotics. So if you were teaching somebody about taking any antibiotics, you should have all of those directions, and then should speak to these common side effects or common effects. So all antibiotics have the potential to cause an allergy. Some cause allergies more commonly than others, but any medication really has that potential. So part of understanding that is that what is, as we've talked about before when we talked about lisinopril, if the person has an itchy rash, the hives, that's something to call the provider about, and then you, as if you were working as the nurse in the clinic, would discuss it with the provider to see, if they want the patient to be seen, or do they want the patient to switch antibiotics or stop them or whatever. If the patient is calling because they have trouble with breathing, or there's any swelling to the face, especially the mouth, more of like that angioedema situation, then it's proceed to the hospital, because that could be an acute anaphylactic reaction. All antibiotics have the potential to cause some degree of nausea, vomiting, and diarrhea. This diarrhea is different than the C. diff diarrhea. This diarrhea just means that stools are soft and more frequent than your usual pattern because it's really dependent on how often the person usually goes. And the reason this occurs is because the GI tract itself is lined with bacteria. And if I take an antibiotic, it's possible that I will readjust, change the flora of the bacteria in my bowel. And so there will be some kind of GI issue. Some antibiotics actually increase peristalsis, so that can also increase the issue. So the person should expect that. And that's why sometimes they do have to take it with food. The issue is that beyond the usual nausea, vomiting, diarrhea, there are antibiotics that can cause what are called super infections or supra infections, meaning that it's an infection in addition to the one that the patient was originally being treated for. And this is related to a change in the bacteria of the body. So if the antibiotic I'm taking kills off some of my normal bacteria, then other agents, one case would be C. diff, the other is fungus, will be allowed to overgrow, and those things can cause me symptoms. So if in the case of a person with Clostridium difficile, that is a bacteria that is present in the bowel in a small amount, but certain antibiotics will kill off the bacteria that are all supposed to live in harmony together, and that will allow the C. diff to overgrow, which will cause a very sometimes crampy pain, sometimes really no abdominal pain, but usually a very malodorous, watery stool. But it has to be water, not soft. So if the patient told you, I think I have diarrhea, and they actually presented the lab with a soft stool, they wouldn't even test it because you can't have C. diff without a watery stool. So that's the key difference when you're asking somebody about their diarrhea, and that's a key distinction for you on any kind of test. The other issue that can occur is in the mouth and vaginal area. Antibiotics can kill off normal bacteria flora, our normal flora, and allow fungus to overgrow. In the mouth, that presents as an oral thrush. So sometimes you can see the white coating, but sometimes it's just a change in taste, or kind of like a discomfort to the tongue, and you might not see the white coating. All of those things are possible. A vaginal fungal infection usually increases itching, and then there could be, or often is, a discharge that is like a white cottage cheese consistency. And I bring that up because you should always ask and not just assume it's a fungal infection from an antibiotic, because people can still have more than one thing wrong at the same time. I mean, there's other types of infections that can cause vaginal discharge. So, gotta be sure that you're just discussing a fungal infection.
Do antibiotics cause yeast infections?
They do, because at least they're one of the culprits of yeast infections. Anything that changes the bacteria flora in the vaginal area can potentially lead to a fungal infection, because that environment is supposed to be acidic, and if we change the pH at all, or we change the bacteria content, will cause a yeast infection. So antibiotics are a culprit, but other things can be too. There are ways to help people prevent these super infections, especially if we know that they're possible and we're worried. Like, I don't want anyone to have C. diff. That's terrible. And some people, it's really hard to get it to go away. But for an elderly person, C. diff can require prolonged hospitalization. It can really debilitate them. They may never really recover from that C. diff. And some C. diff produces so much toxin in the bowel that it can dilate your colon so much so that it could burst. And the mortality rate from what's called a toxic megacolon from C. diff is extremely high. It's like 80 to 90%. So I don't want people to get those. And yes, stool transplant is actually a really good treatment. And what you're doing is you're seeding, you're giving the person with the infected bowel good bacteria to get rid of, to kind of change the balance again. But there's other things you can do. Oh yeah, for people who have seed, yeah, you want to be sure that hopefully they don't get the infection. So one is, prescribers. You guys don't prescribe, but that's why one of the reasons why you don't just give antibiotics to everybody, because they're not without their own issues. The other thing is, what can people do to protect themselves? You can try to kind of grow your good bacteria to protect your bowel. And so that's eating yogurt, yes, use, or taking like a supplement like Floragel, or yeah, kefir or kefir. I never know how to say that. Probiotics, exactly. Something that will help protect the person's normal bacteria. It's always good advice to give people so you can protect them from having a problem. So that's all of the material that could potentially be on next week's quiz. Now we're going to start talking about antibiotics. And it might be that we don't get to do the study sheets today. There's so much material, but that's okay. We will do them. Oops, that's the only one. I'm just going to keep pressing buttons until I get the right one. Content. I want antibiotics. And then I'll just announce right now, I'm setting this up, that if you haven't, I'm keeping a record of everybody that checked back in, and I do have, obviously, this video to go back on, but if you have not checked in on the side here, where I have marked everybody, then please do so, or you won't get credit for attendance for this afternoon. So if you're one of the people that haven't checked in, then please do so. All right, antibiotics. So we mentioned before lunch that antibiotics work in several ways to kill or stop a bacteria from dividing. And the first overall grouping of antibiotics we're going to talk about are antibiotics that actually stop, either break up the cell wall or stop the cell wall from being repaired. So they like destroy the bacteria. And the first antibiotic that we'll talk about is penicillin. So in the first class, we talked about therapeutic class, pharmacologic class, and prototype drugs. So this therapeutic class is getting rid of bacterial infections. These are antibiotics. The mechanism of action of pharmacologic class is to inhibit cell wall synthesis or damage the cell wall. And this first type is penicillin. There are other types of penicillins. All penicillins end with "cillin." In fact, the original penicillin that was created, there's a lot of antibiotic resistance. Thanks, Aisha. I have you recorded. There's a lot of antibiotic resistance to penicillin in general. So usually people will use amoxicillin or the combination amoxicillin clavulanate or clavulanic acid. So those are the two you see with the stars on them, because those are the two that could be on the exam. And the way they work is they bind to the bacteria cell wall, weakening the wall, and then killing the cell. And the reason they're able to do that is their chemical structure has something called a beta-lactam ring. So we never have to memorize chemical structures, except in this particular case, the part of the chemical structure of the antibiotic penicillin contains this thing, which is sort of like almost like a cleaver. It opens up the cell walls. So that's the beta-lactam ring. The part that's interesting and why there is some resistance to penicillins is that bacteria have developed an innovation to get rid of this beta-lactam ring. Some bacteria produce an enzyme called beta-lactamase, and beta-lactamase can get rid of the ring, which makes the antibiotic useless. And so that is the reason to pair amoxicillin or a penicillin with clavulanic acid or clavulanate, because that medication gets rid of beta-lactamase. So it's kind of complicated, so I'm going to say it again for you. There's a couple of reasons why you have to know it. One reason you have to know that penicillin makes the beta-lactam ring is that it helps to explain cross allergy that occurs in penicillin. And the other reason you have to know it is that it's telling you why people have, people sometimes have issues with resistance because bacteria have developed beta-lactamase, which can get rid of the beta-lactam ring, and so the medicine doesn't work. But it also tells you why medications can be added to antibiotics. So clavulanic acid, this medicine right here, that isn't an antibiotic. The only thing it's doing is destroying beta-lactamase so that the amoxicillin can still work. So that's why that can be added. So if you're wondering, what is amoxicillin clavulanic acid, the brand name of that is Augmentin, which is in the same family as penicillin. It just has that addition to decrease resistance. So we talked about that. Again, we have, these are all things that we've just talked about that all antibiotics have the potential to have. GI upset, allergy, super infections, which would include C. diff and the oral and vaginal fungal infections. It would be best if you gave the penicillin, amoxicillin, or whatever at the beginning of a meal before you eat. But sometimes that's not possible for people. They might have to take it after, but that's what you would like. For infants and small children, because amoxicillin is a frequently prescribed suspension for children, you can either take like a dropper and place it on their tongue, or you could mix it with a small amount of juice or formula that is allowed. It's very hard to give young people, babies and toddlers, antibiotics. So that's an attempt to make it less of a rough situation. If the antibiotic comes in an extended release form, then it cannot be crushed. If the person has a kidney problem, the dose might have to be reduced. It's not that penicillin causes kidney problems. It's just that if someone has kidney problems, the drug will metabolize differently and it will stay inside the system longer. The one key thing, and usually I have 1 or 2 students a semester that will say, oh yeah, that's how I had my baby, is that people taking antibiotics, especially penicillin and sulfa antibiotics, need to be told that it decreases the effectiveness of oral contraceptives. So they have an increased chance of getting pregnant because it's not going to work. So that is very, very important to tell people that are sexually active and on oral contraceptive medications. Okay, so that's we're talking about medications that take care of bacterial infections. The pharmacologic action is to break the cell wall. The first class is penicillins, and our prototype was amoxicillin and amoxicillin clavulanic acid. So now we're still in the same therapeutic and pharmacologic, we're still in the same therapeutic class. Our pharmacologic class still is destroying the cell wall. This family, instead of penicillin, is cephalosporins. And our prototype cephalosporin are the two that's listed there, cephalaxin and cefotetan. Cephalaxin is the most commonly used one, and that's Keflex. Cefotetan is listed there because it is used for meningitis specifically and has its own special adverse effects. So that's why it's listed separately. Again, we're binding to the cell wall and stopping cell wall synthesis. There are 5 generations of cephalosporins. There are many, many types of cephalosporins. If you are taking a test or confront a medication where the first 3 letters are ceph, That is a cephalosporin. They all begin that way. Their generic names do. There is a cross allergy between cephalosporin and penicillin, and that's because they both have the beta-lactam ring. It's not completely the same, so it's different enough that this is a different class of medications, but it's close enough that for some people, 5% of the people who are allergic to penicillin will also be allergic to this group of medications. That's important. That's always on the exam. It's the cross allergy. There was a cross allergy on today's exam. Does anyone remember what that cross allergy was? It was sulfa and what drug? That's correct. Sulfa has that cross allergy with furosemide because they're similar chemically. All right. So, cephalosporins, same side effects. We have the same issues as we did with, yes, furosemide, thank you. We had the same issues that we have always talked about, GI issues, potential allergies, and we have to worry about super infections. Some extra things that we have to worry about with the cephalosporins is what's called a disulfiram reaction. So we never really want to give, we don't want people who are sick to be drinking alcohol in general. People that have an active infection should not be drinking alcohol because it's dehydrating. But certain antibiotics, we definitely don't want them to drink alcohol because it'll make them feel sick. Disulfiram is a medication, actually. It's called Antibuse. That was the brand name for it. And the whole point of Antibuse was that if you were alcoholic, maybe you would be not so likely to drink if you felt sick when you drank. So the idea was you would take Antibuse or this disulfiram daily, and then if you drank alcohol, you would experience these symptoms: nausea, vomiting, headache, potential decrease in blood pressure, so you feel dizzy and lightheaded, so you feel sick. Obviously, there's a clear way around that. You just don't take the disulfiram and then you can drink. You won't feel sick. So it's not like the most successful drug on the market. But if any drug is similar to the chemical structure of Antibuse, then when the person drinks alcohol, they will also have those symptoms: nausea, vomiting, headache, lightheaded, dizziness, potential low blood pressure. That's a disulfiram reaction. And cephalosporins are one of those antibiotics that can cause that, especially with cephalotetan. And people who are on cephalotetan can also have an increased risk of bleeding. So that's why it was pulled out and discussed separately, different from all the other cephalosporins. Just like with penicillins, we might have to make adjustments in the case of renal disease. This medication, when given IV, can cause thrombophlebitis, meaning the vein gets infused. So you have to be careful that you give it slowly to decrease that likelihood. Okay, so again, we're still talking about antibiotics. So we're killing bacteria. We're talking about antibiotics that damage the cell wall, and the vein gets that, correct. So if you were giving, Natalie is asking if the vein gets the thrombophlebitis, and that's correct. If you were giving the antibiotic as an IV infusion, whatever vein that IV is in gets inflamed and irritated, especially if the medication is given too fast. So if that occurs, it doesn't mean that the patient's allergic to the medication or they can't get it again. Probably you'll have to change the vein that you're running the medicine in, and then you'll just have to talk to the pharmacist about running it slower. Okay, so we're antibiotics, we're destroying cell walls. We talked about penicillins, and then that was amoxicillin and amoxicillin clavulanic acid. And then we talked about cephalosporins, and that was cephalexin and cephalotetan. And now we're talking about monobactams, which are in the same, we're still in the same pharmacologic class of breaking cell walls, but this is a different family, and this is what we call a narrow spectrum antibiotic. So penicillins and cephalosporins are broad spectrum. You can give them to treat multiple types of bacteria. Azactam is used for gram-negative aerobes, a very specific type of bacteria. So this isn't given a lot, only when that's the only choice, essentially. So this is usually a medication that's given IV. So we again have to worry about thrombophlebitis when we're giving this medication through an IV. And this medication is also incompatible with multiple other IV medications. So what does that mean? Usually what that means is, say the patient is getting more than one antibiotic. Well, you can't just use the same tubing. Azactam would have to have its own separate tubing. Or say the patient is getting a continuous infusion that has medicine in it, like heparin. You couldn't run, you couldn't group them together, like piggyback the Azactam in with heparin because of the incompatibilities. You would never do that. So you have to be sure. And the reason that's bad is if you give Azactam with a medication that is incompatible with it, there could be what sometimes develops is like sand. It causes precipitation, which means you can see sand in the IV tubing, which could lead to an embolus. So you don't want to do that, obviously. Other issues, it has to do with abdominal pain and some seizures and respiratory symptoms similar to an asthma attack. So that's not very common, but is possible. And you won't really give this medication a lot, only in select circumstances in the hospital. Okay, we're still in the antibiotic cell wall destruction. Talked about penicillins, which is amoxicillin, cephalosporins, cephalaxin, cefotetan, monobactams, and that's Azactam, and now we're carbapenems, and that is imipenem. So this is our strongest antibiotic. This is the biggest gun we have. It's the best we can do. So we have to protect it. We don't want to overuse it because there is already been people who have been carbapenem resistant. And that would be bad because if you're resistant to carbapenems, there's nothing else we can give you. We just have to support you through the infection and hope that you make it. And most people don't. So this is a very strong antibiotic that's used in the hospital as an IV medication. It has to, or IM, but mostly IV, in order to take care of serious infections, like if someone's bowel perforated and they had a huge abscess in their abdomen or something like that. It's going to be a really bad infection for the patient. So our prototype carbapenem is imipenem. And again, just like with all the other IV antibiotics, we had to worry about thrombophlebitis. And we don't want to give it too fast because we could make the person vomit or feel sick. We always have to worry about secondary infections, but we have an extra caution with seizure disorders or neurotoxicity. Okay, we'll talk about this last antibiotic in this class, and then we'll take a break. So again, vancomycin is our last class of antibiotics that inhibit the cell wall. So vancomycin is its own class of medications. It's unfortunate that there are several classes of antibiotics that end in the word mycin, but they're not related. So it's not like penicillins, we can say all cillins are penicillins, and we can't say all cephs are cephalosporins. In this case, it's vancomycin, and it's just by itself. Vancomycin is very good medication for resistant infections. If you give it orally, it does not absorb into the general circulation, so it only stays in the bowel. So it is one of the gold standard first drugs of choice for treatment of a C. diff infection because it just stays in the bowel. If you're giving it IV, it does work for multiple resistant types of infections, and you have to give it dilute over 60 minutes to prevent a generalized flushing and hypotension. So the person becomes so flushed that person becomes red, like their whole body becomes red. So that's why it's given this name. It used to be called red man syndrome, which obviously is not gender inclusive because women can get it too, and it also sounds kind of racist to Native Americans. But the current term is red person syndrome. But essentially, what happens is the person turns red and has low blood pressure because of the release of histamine. This has inflammation of the vein. This has multiple IV incompatibilities. You have to be very careful. It can cause nephrotoxicity and ototoxicity. So nephrotoxicity is kidney
When you
function.
say dilute, when you say you are supposed to dilute it over 60 minutes, is the vancomycin the one that has like the glass bottle at the top with the bag of solution and you have to like go back and forth mixing them up?
Oh. So not this one. It's already pre-mixed for you, so the pharmacist will have to dilute it into a large volume of fluid. They'll do
So
it
what
for
do you
you. There
mean
are
when you say,
antibiotics.
what do you mean when you say dilute it over 60 minutes?
I mean that they're going to give you, the pharmacist is going to give you a pre-mixed bag, and it's going to be a bigger bag. Like instead of a little mini bag of 50 milliliters, it's going to be like 150 milliliters or 200 milliliters. And instead of
So
giving
it'll
it like
be diluted and then given over 60 minutes through that IV.
correct. Whereas what you're talking about, Lillian, sometimes those are usually like cephalosporins sometimes or penicillins, and where you get the little mini bag that's like maybe 50 milliliters of fluid, and then there's that little glass bottle, and then you kind of break it so you can mix it yourself. It depends on the type of antibiotic, whether or not you can mix it yourself on the spot or if it has to be pre-mixed. Either way, you're still diluting it. It's just that this is diluted over a larger volume. It's just that some medications, if they sit in fluid for too long, will become inactive. So you have to dilute them right before you give them. Which, of course, everything is always like super complicated. So nephrotoxicity means our kidneys aren't working really well. So how will we know our kidneys aren't working well?
Swelling?
Because the kidney's job is to filter fluid and get rid of waste in the urine. And so if we're not filtering the excess fluid, we will keep the fluid. So we will have swelling, like Lillian said, edema. It'll affect our blood pressure, potentially our urine color. The most sensitive measure to fluid, what is the most sensitive measure of fluid status?
Repeat that again.
So if you're wondering if there's a change in fluid status of your patient, like either they're losing too much fluid or gaining too much fluid, what is the most sensitive piece of information? Well, we'll pick that up before anything else.
Their weight?
It is the weight. I think that's the most sensitive indicator of fluid status is the weight. So their weight would go up. They'll probably have swelling. Their blood pressure might go up too, but it won't go up as fast as the weight will. Like you'll see the weight first. And then I saw someone put lab results, and that's specifically the BUN and creatinine. And the other issue that can happen with vancomycin is ototoxicity, which means damage to the ears. So remember, that doesn't just mean hearing, it also means balance, because The ear also has the semicircular canals inside that are responsible for maintaining balance and equilibrium. And so if that's damaged, the person could feel dizzy or have a sense of vertigo, as well as a decrease in hearing. So the worry about the kidneys is so great with vancomycin that peak and trough measurements are needed. So I don't know if you remember when we talked about doing like trough measurements in the beginning of the semester, which seems like 5 years ago, but it really wasn't that long ago. So after the person has been getting the medication for a while, we would expect that they would be in somewhat of a therapeutic index. And at the lowest point, before the next dose, is the trough. We would expect it to be within the therapeutic index, but not too high and not too low. So we had that graph that had the time you take the medication, it was onset of action, peak, duration of action, and then gone. Hopefully that's somewhat memorable to you. Like here's our peak right here. When we're taking an antibiotic, we're hoping that we're always in this therapeutic window so that the patient is always getting medication. They're always getting enough that their infection will be taken care of. So that each dose, if this is the therapeutic index right here, that therapeutic index, we're always maintaining with each dose that we're inside the therapeutic index. Like this is 1 dose, 2 dose, 3 dose, 4 dose. So what the pharmacist or the provider will say is they'll pick a dose. It could be anyone. They could say before the 3rd dose, so right here, check a trough level so we can see where we're at. So right before you give this dose, you got to be sure that the lab comes and obtains this level. What that's telling us, what we want to know is it below the therapeutic index? Because if the trough is below the therapeutic index, what do we need to do to the medication?
When you say that we have to, like they might ask us to check the trough, is it going to be a chart like this? Or are we looking at lab diagnostics or that lab stuff?
You're looking at lab stuff, but that's what the lab is supposed to be indicating.
So it'll be a chart with that wave on there.
Well, the pharmacist will have that chart. What you'll see is Vanco trough, a lab that'll say like 0.73, and you'll know if that's too high or too low. You'll get a lab value. But this is what the pharmacist is tracking. Are we staying within this therapeutic serum level? So they'll say, okay, before this 3rd dose, get this blood test, and we're going to see what it is, because if it's too low, then we know that the patient is coming out of the therapeutic window. And that means, as Natalie said, that the dose will have to be increased. Okay, 1 second before I answer that, Natalie. So that means that the dose has to be increased. If I got the trough level and it was actually way up here, or even out here, so high, this is supposed to be the lowest point. That means some of the time I'm out of the therapeutic window. I'm toxic. Then I have to worry that I'm actually going to hurt the patient's kidneys, which can happen. People have developed temporary or permanent kidney failure from being on vancomycin. So this has to be watched very, very closely. And if that was the case, if the vanco level that you saw as the lab test was too high, then they might actually skip a dose or decrease the dose or do something. It's not that you would have to decide what to do, but you have to be sure that this is getting taken care of. Because if the provider ordered a trough before the 3rd dose and you didn't see that order and you gave the medicine before the trough could be ordered, then we have to wait a full another 24 hours to find out if the patient is toxic. So it's extremely important that you follow this because you're trying to, one, be sure the patient gets treated for their serious infection, and two, be sure that they don't develop kidney failure. So let's see, how long after giving the other dose do you have to draw the trough level? So are you asking, Natalie, like how long
Like,
after the dose before?
yeah, like how long after dose 2 do you need to draw the lab to know what, like,
Oh, yes. So you want that level to be the lowest level in the blood, which should always be right before the third dose. So I would have to be sure that that is being drawn and then give my medication. So it's going to happen that I'm going to have dose number 3 hanging before we get the result of the trough. And so we're influencing dose number 4.
so like if the medicine is every 12 hours, then it would be like 12 hours after that other dose that it's actually measuring the lowest level.
Yes, exactly. Because at this point, once the next dose is due, I should be at the lowest level in my bloodstream. It should still be within the therapeutic window, hopefully, but that's right before the next dose is due will be the lowest level. So I'll give it right here. I might not get the results until dose 3 has been hanging, and therefore the pharmacist will end up changing what happens with dose 4. But then you can see if I messed it up, if I forgot or didn't take care of that before dose 3, then I'm delaying the medication changes, for whatever, a day. Sometimes vancomycin is only given every 24 hours, and then I've delayed finding a problem for that patient. So on that note, we'll take a little break till 2 o'clock. It's 1:50 right now. And then we'll pick up where we left off. So I'm going to pause and step off the call.
Trough is a low.
Right, it's the lowest point. So I'm checking it before I would give the next dose, so I know if the patient is in the therapeutic window for the medicine. And if the lowest, if I draw the trough and the patient is out of the therapeutic window, that means that the dose needs to be increased. And if I draw the trough and they're too high within the therapeutic window or above it, then the dose has to be decreased. So that's important, obviously, for the exam. Not for the quiz. That won't be on the quiz, but that will definitely be on the exam. Okay. I have everybody recorded for attendance, but there's more people on the participant list than the people that acknowledged they were here. And so specifically, if let's see, I think Courtney, did you say that you were here?
Yeah, I'm here.
Okay, good. I just want to be sure. I don't see you on the side saying you were here. Did you type in that you were here?
I must have completely forgot. I apologize.
Okay, no, I just want to be sure that you get credit.
Well, thank you.
And then Devin, Devin, I don't see that you're signed in. I mean, I see you on the top, but I don't see you as someone that said they were here. So I'm not sure if you're really here, Devin. Making me think you're not. Okay, Courtney is here. Thank you, Courtney. But so far, I'm not giving Devin any credit. It's going to be on the recording even. So, because I'm already recording. Busted, right? I know how that goes. I have the social medias. Okay, so back. Angelique is here. I got you. I had you down. Yeah, just Devin. Devin's trying to trick me. Okay, so all right. now we are still on antibiotics, but we're switching pharmacologic class. We're not talking about medications that change cell wall. Now we're talking about medications that stop synthesis of protein. And all cells need to make proteins in order to stay functioning. That you need to repair themselves and to help get themselves ready to replicate. So if you cannot make proteins, you're not going to be able to survive. So that it's still going to work to get rid of these bacteria, just in a different way. So antibiotics that inhibit protein synthesis, first family within that is the tetracyclines. Our prototype drug is doxycycline. And tetracycline is a medication too, but there's so much resistance that you really can't use tetracycline at all. Doxycycline is the one that is used. It has good coverage. These are some of the things it's commonly used for: different sexually transmitted infections and acne. Again, we have the same GI issues and secondary infections, but then we have some extra things here. Liver toxicity, photosensitivity, it says teeth, which sounds weird, but there's a tooth issue. So liver toxicity, that means now we're switching gears from kidneys to the liver. So what are symptoms we might see with liver toxicity?
Jaundice.
Jaundice. So if the liver isn't working well, then that means we're going to have extra bilirubin in our bloodstream instead of being taken care of by the liver. So the patient will have jaundice. The sclera will be icterix. That looks yellow. The urine is
Potentially edema.
Yes, potentially edema. Who said that? Was that you, Devin?
Yeah.
Then why don't you say you're here? Did you hear me talk about you for the last 20 minutes?
Oh, I'm sorry.
Seriously, I called you out for like a good 10 minutes when we first came in here.
I'm so sorry about that. I went to use the bathroom. I'm sorry.
Yeah, well, if you listen to the recording, it'll be kind of funny because I'll be like, Devin, I know you're faking it. I'm like,
oh, I'm sorry about that.
Well, at least I can give you attendance credit then.
I'm definitely gonna have to listen to the recording because that's gonna be pretty funny.
Sure. Yeah, that's what Natalie said. You were called out. You were. I say I gave it a good 5 minutes. It's hilarious. All right. Okay. So potentially you could have edema. What are the blood tests that you would see a difference in? No, that's the kidney.
Would it be low blood cell count because of anemia?
No, you're over the long term maybe, but you're more like you're gonna see a change in the bilirubin level and the ALT and the AST, because those are the liver enzymes that you'll see in the bloodstream. They don't belong there. So if they're there, that means there's been some destruction or damage of the liver. So if you're worried about liver toxicity, you might have some complaints of abdominal pain. You might, which will be hard to distinguish because antibiotics cause that. The patient will have the jaundice. They may have dark urine or light stool, and the blood test that we would check would be liver function panel, bilirubin, ALT, and AST. Photosensitivity, we were talking about that earlier, means that taking this medication makes you very sensitive to the sun. So if the patient is in the sun, they could actually get a severe burn. So while the person is on doxycycline, they should avoid the sun. So that's key information for the exam about patient education. If the issue is potential photosensitivity, then they should stay out of the sun. They should wear sun hats or long sleeves. Always use sunblock. It doesn't matter the melanin content in the patient or in the person's skin. You could be light skinned or dark skinned. You still have the potential for burning. And then there's this weird thing that can happen to people's teeth. So, sorry, before we get to the teeth thing.
Isn't it plaque
What?
buildup?
No, it's permanent staining. So, some other rules about tetracycline and doxycycline, just really quick, is that it is best on an empty stomach, but obviously, if you have to eat it with food, take it with food, you can, but you must not take it with calcium. So, even if, say, you tried to do it without food and you couldn't because you got too much stomach upset, so you decided to take it with food, it must be non dairy foods. Otherwise, the medication will not absorb. And sometimes, if people take it and lay down right away, they can get like a reflux. So, you don't want to take it too close to bed. This issue, it actually permanently discolors the teeth. They become gray like that, and there's nothing you can do to get rid of that. You cannot try to do a whitening procedure, it doesn't work. Um, and so, for that reason, pregnant women and children under 8 should not take this medicine. So, if a woman is pregnant and she takes this medicine, the child's baby teeth that are there will be stained. It'll go through the placenta and into the child developing fetus's bloodstream and cause staining of the baby's teeth, which would be permanent. If the person the you know everything's fine with the pregnancy, then they decide to give it to a child. The child's teeth, adult teeth, will be permanently stained. So you're just supposed to avoid it in pregnant women and children. Okay, the next class, so we're still antibiotics. We are in the pharmacologic class of medications that inhibit protein synthesis. And now we are talking about the family of macrolides. And the prototype drugs are erythromycin and azithromycin. Azithromycin might be familiar to many people. It is often prescribed incorrectly for viral bronchitis because most of the time, or sinusitis, it's not actually the first choice for those conditions, especially for healthy adults who probably have a viral infection. So azithromycin and erythromycin are very good for people that are allergic to penicillin because it's a completely different chemical structure. So we don't have to worry about that cross allergy issue that we had before. Erythromycin, the biggest difference between erythromycin and azithromycin is the half-life. So erythromycin has a very short half-life, and so you have to take it multiple times a day, and most people don't use that medication anymore. Azithromycin is long-acting, and so you only have to take it once a day, and that's why you need a loading dose. So azithromycin is a traditional Z-Pak, a 5-day treatment. The first day you take 500 milligrams, and the subsequent 4 days you take 250 milligrams. And you needed to take that loading dose so that you could get into the therapeutic window faster. There are many drug interactions. This is another one of those medicines that you cannot have grapefruit juice with because it increases the risk of toxicity. What were the medications that we talked about for the cardiovascular unit that had interactions with grape juice? Should be rolling off your tongue.
It's atorvastatin, nifedipine, and amiodarone.
Yes. So the 3 that we talked about in class, not with grape juice, is, and I know sometimes people don't want to say because they don't like to pronounce them, but you did pretty good, I have to say, is nifedipine, atorvastatin, and amiodarone. Those were the 3 medications that we talked about that you should avoid grapefruit juice with because it increases the risk of toxicity. Again, we have to worry about GI side effects and secondary infections. We just have different toxicities to worry about. We have the odle toxicity, which could be permanent hearing loss, and cardiac toxicity, which we have not talked about yet. This medication can cause a particular type of arrhythmia that can be quite dangerous. It's called a prolonged QT. And this type of arrhythmia can, if it's allowed to continue, or the person takes multiple medications that could prolong the QT, it can lead to a specific condition called torsades. I don't know if anyone's ever heard of this. It's a type of VFib that looks like it gets really tiny and then really big and then really tiny and then really big. So it's bad. So we have to be careful about that. All right, the last class of antibiotics. This is antibiotics that affect protein synthesis. The class is amino glycosides. Our prototype is gentamicin. This is another narrow spectrum, especially when given IV antibiotics. So we're very powerful, reserving for serious infections. You might notice it given in other forms for common things. People sometimes get gentamicin eye drops or ear drops. But if the other way to give it is IV, and it's one of the ones that will be given as an inpatient in the hospital for serious infection. This is another one. It's IV, so we have to worry about thrombophlebitis. We have to worry about multiple incompatibilities. And because of the risk of oto and renal toxicity, just like with vancomycin, we have to do those peak and trough measurements again. And so if we got that, if the trough level showed that the level was below the therapeutic window, that means that the gentamicin dose would have to be changed. It would have to be what? Increased or decreased?
Increased.
Right, it would have to be increased. Or if the trough showed that there was, if the trough showed that the level was very high in the therapeutic window or above the therapeutic window, then we'd have to decrease or skip a dose. All right, so now we're off into another group of antibiotics. So we have, for antibiotics, we talked about ones that affect the cell wall. We talked about ones that affect protein synthesis. Now we're talking about ones that affect DNA replication directly. So then the bacteria cannot divide. And if we, this particular class is fluoroquinolones, and our prototype is ciprofloxacin. So ciprofloxacin is a very good antibiotic. It is a broad spectrum antibiotic. It can be used for multiple things. But it's not without its own issues. So there could be, especially for elderly people, there can be some headache and mild confusion. We still have the same things we have to worry about with in terms of administration and side effects, with GI side effects and super infections. In fact, this is one drug that is very frequently involved in C. diff infections. It is one that causes sun sensitivity, just like doxycycline does. So we want to be sure the patient stays out of the sun or covers themselves if they're out. We don't want them to take it with food, but if they do, again, we have to separate from dairy items. We have to keep away from calcium and decrease caffeine and antacid use because that changes the absorption. And then this one has a very weird thing that can happen sometimes, and it's called Achilles tendon ruptures. So your Achilles tendon is connecting your calf muscle to your heel, and for some reason Cipro can cause increase in fluid in your tendon, so it can cause your tendons to swell. Especially affected is the Achilles tendon or the patella tendons around your knee. And if those tendons swell, they start to hurt. The problem is sometimes they swell so much that they actually tear, which is extremely painful and actually a really long rehab. If you would tear your Achilles tendon, which is a very thick tendon, it can be a full year before you recover from an injury like that. So if the patient is on this medication and develops heel pain, they should call right away, and they need to not be on it anymore. So that always ends up being a test question. And then, as we're working our way through here, that was our only medication with the pharmacologic effect or mechanism of action of stopping DNA synthesis. Now, for antibiotics, this pharmacologic effect is to inhibit folic acid. Inhibiting folic acid changes how DNA can divide and how it is structured. So it does end up stopping the ability to divide the bacteria. And our main class is sulfonamides, and our prototype drug is sulfamethoxazole, and it's always paired with trimethoprim. You can't give sulfa without trimethoprim due to the resistance. So trimethoprim is sort of like clavulanic acid in that combining it with the sulfamethoxazole will decrease resistance to that medication. Again, this increasing water intake is especially important for this medicine, but it always is important in general. This is another disulfiram reaction with alcohol, like the cephalosporin was that we talked about. This has a very strong interaction with oral contraceptives like penicillin that we talked about. This is not good. It's not a good idea to combine this medication with methotrexate, as that increases the possibility of immunosuppression. Allergies, superinfections, GI symptoms, those are things we've talked about with every one of these. The other issue here is Stevens-Johnson syndrome. So there was some confusion between Stevens-Johnson syndrome and toxic epidermal necrosis with our first exam. So what are the symptoms of Stevens-Johnson syndrome?
Do you have a butterfly rash?
So the butterfly rash is the lupus, and skin sloughing, I hear that Kelsey put, that's toxic epidermal necrosis. So Stevens-Johnson syndrome, can be a fever associated with it, because there's usually, you start taking the medication and you develop symptoms of an upper respiratory infection. So say I was on sulfa, or what the brand name for that sulfa is Bactrim. Say I'm on Bactrim for a urinary tract infection. A couple days into that therapy, I start to feel like I have an upper respiratory infection, like maybe fever, fatigue. I might have like a cough and stuff like that. And then I developed a skin rash that looks like blisters or pimples to my torso area. And over time, that sort of grows together. So I get this really, really red rash. But the key difference is the upper respiratory infection symptoms followed by a skin rash that starts on the torso, as opposed to toxic epidermal necrosis, which is the top layer of the skin dies and then will slough off because it's dead, sort of like the skin of a snake. So that's the difference between those two. So sulfonamides, or sulfamethoxazole, and trimethoprim, which is trimethoprim, which is Bactrim, can cause the Stevens-Johnson syndrome. So this is, can be a select all question or a question on the exam where the question is, patient starts this medication, and you might get like a series of choices, people calling with potential problems, and which one are you worried about the most? If it's the symptoms that I just described of Stevens-Johnson syndrome, that's a top pick, because this person is potentially in danger if they're starting to develop this. It's a severe skin reaction. Bone marrow suppression. What are the cells that are made in the bone marrow?
white blood cells, red blood cells.
And that's true, those two are correct, and one more type.
Neutrophils?
Oh no, that's a good chance, because neutrophils are a type of white blood cell. It's platelets, actually. So the three main types of cells, and white blood cells includes all those types of white blood cells, so including neutrophils, but white blood cells, red blood cells, and platelets are all made in the bone marrow. So if a patient is taking a medication that could potentially cause bone marrow suppression, that means they could have a low white blood cell count, a low red blood cell count, and a low platelet count, which makes them at risk for infection, anemia, and bleeding. So this is rare, but also possible. And the last medication, we're just gonna cross that out. So don't even worry about that one. So that's antibiotics. Whew, that's a lot of stuff. We'll wait to do those study sheets and actually do them in the beginning of class next time. We'll just start, let's see, where are we? I was putting together the study guide for you guys. We'll do parasites because that's a quicker one. It's a good way to end with some bugs. Okay, so this section is medications for infections that are caused by parasites, which are essentially little bugs, little creatures, those very complex organism, much more complex than bacteria is. So a parasite is a single-celled organism that lives off of another structure. So a parasite can't live unless it's connected to another living host so that it can take what it needs from that host. And
like a baby?
Parasites, yes, a baby is the scientific definition of a parasite. It is. It's living off of you, taking things from you to live. Parasites are typically found in water, soil, and other animals. So that's how humans might come in contact with them. If their water source is contaminated, sometimes with animal waste, that's a really good way for people to get parasites. But that's where they can usually be found. So there are several types of parasites that you will commonly see. There are some GI infections that are caused by parasites like Giardia, which is from contaminated water, or there is a sexually transmitted infection called trichomoniasis that is also a parasite, which is a frequent infection. And the best medication to use for those types of infections like Giardia or trichomoniasis is a medication called metronidazole. So metronidazole you might see prescribed for other things. It's actually sometimes used to treat other infections like tooth infections or other abdominal infections. It was one of the first treatments for C. diff, although it doesn't work as well for that anymore because of resistance. Its brand name is Flagyl, so you may have seen it in that way. So metronidazole, we're going to talk about it as an example of a very good antiparasitic medication, but it is used for other things. So it enters the parasite and damages the parasite's DNA, which is how it ends up killing the parasite. It is best to take without food, but if you need to, you could take it with food or milk. There's no dairy thing you have to worry about. It comes in multiple forms. depending on where your infection is located. We're talking about people that might need to take it as tablets. It does have that risk of a disulfiram reaction, which means, um, you like the pictures of the parasites, Natalie? I think they're so sweet. Which does mean that it can has that interaction with alcohol. The interaction between flagyl or metronidazole and alcohol is actually quite strong. And people will get very ill if they drink alcohol while on this medication. It does also, besides the usual GI effects, will cause a weird metallic taste in the mouth, almost like you're sucking on a penny. So that will be present as long as the patient is taking that medicine. Once they stop, that metallic taste goes away. But it is kind of irritating. They might notice a change in the color of the urine, but that's harmless, so that's something you just need to tell them about. The most severe issue that can occur is what is considered neurotoxicities. They get headache, vertigo means they get dizzy, ataxia means they have balance problems, and the worst would be seizures. And then the last medication here, so that was metronidazole to treat some parasitic infections. The last medication that we'll talk about in this as anti-parasite is chloroquine, which we sort of talked about chloroquine before because the other way it's marketed is hydroxychloroquine. We talked about that as a way to decrease inflammation in rheumatoid arthritis. It was not really known why it does that, but it does. The way you can give chloroquine as a treatment for malaria or as a prophylaxis for malaria. So malaria is a mosquito-borne illness, and it's a parasite that lives in the mosquito, and then when the mosquito bites you, it transfers that parasite to the person, to the human host. And when that happens, the parasite likes to go into the person's red blood cell. There's your little bug. So at first, the person doesn't have a lot of symptoms. Inside the person's red blood cell, the parasite will grow and multiply. So the person's red blood cell will become very large. And eventually will pop, and all the little parasites will be in the bloodstream then, free to go infect other red blood cells and to make the person feel really sick. And malaria is endemic in lots of parts of the world and is one of the leading causes of death worldwide from infections because it can be so bad. So if you're traveling to an area where malaria is endemic, meaning that it's there, lots of people get it, then it's wise to treat yourself with prophylactic chloroquine to prevent the infection to begin with. And so that's one reason why people take it. And you would just take it 500 milligrams, one pill per week, starting 1 to 2 weeks before you traveled, and then you stay on it for 4 weeks after you come back. The way chloroquine works is it binds to red blood cells, it's my little chloroquine, so it doesn't allow the parasite to get in. And if the parasite can't get in, then it can't survive because it needs to get into the red blood cell in order to divide to make more. So then once these ones are gone, then the infection is gone. So if I give someone chloroquine ahead of time, then I'm going to bind their red blood cells so the parasite can never get in there. And so you keep taking it so that in the off chance that there is some parasite circulating in there in the time from when you just got home, it can't get inside your red blood cell. And it's specifically a heme complexing agent, meaning it binds to your red blood cells. And that's how it works. Interestingly, in case you're interested in trivia, I like to share every now and again, and this is the reason for the development of sickle cell anemia. So if you're living in an area where malaria is endemic, such as like the Mediterranean or Africa, some areas in South America, and you have sickle cell anemia, if your blood cell can make that sickle shape, then the parasite can't get inside. So people who had the tendency to have sickled red blood cells didn't get malaria, so they were the ones that got to reproduce, and so sickle cell and thus sickle cell anemia developed. For people in a warm climate that aren't stressed, it's not necessarily bad, but if you have a severe sickle cell anemia, malaria, was she on chloroquine and felt sick, or did she have malaria and felt sick? Your sister Natalie.
I thought, I don't really remember, but I know it was like the treatment that she had to take before she went to Africa, and she said it made her feel really, really sick, and they wanted her to stay on it for a long time, and she was talking to me about maybe going off of it and what the risks would be, because she just didn't like the way it made her feel.
Well, if she's still on it, I recommend she not do that, because I would rather.
Oh no,
have
no, she's been there. She's been there for 8 years now. She's not coming back. But it was like right when she went over there. But she's fine now.
Well, that's good. It does have symptoms that don't feel very good. I mean, there's a lot of GI symptoms, headache. For some people, it does cause vision changes, which is why that was one of those test questions on the first exam. The patient who's taking hydroxychloroquine on a regular basis needs to see their eye doctor every 6 months to be sure they're not developing retinal damage that would potentially be reversible if caught early. People on chloroquine for malaria rarely have to worry about vision changes because they're only going to take it for a short period of time for an infection. They're not taking it all the time. It can cause, what's not listed on here, which we know can also cause cardiac, that is not how you spell that, cardiac dysrhythmias, so we would have to watch them for any palpitations or change in their heart rhythm. But there's a lot of GI symptoms. It doesn't really necessarily feel good to take it, but it's better than malaria. So that is our parasites. Any questions about the parasites? Because then I think we'll talk about TB, and then we'll talk about viruses and fungi the next class. So tuberculosis is a mycobacteria. So these infections are very difficult to kill because not only it has an extra waxy wall that other bacteria don't have. So we had our gram-positive or gram-negative bacteria that had different thicknesses of cell walls, and mycobacteria have this extra waxy coating that, besides making it difficult for our immune system to deal with, tends to make our immune system overreact to its presence. So part of the reason why we have the symptoms we do from tuberculosis is because our immune system is going crazy trying to get rid of it. So people get what's called a hypersensitivity reaction, that they have an overactivity of parts of their immune system around the microbes as a way to wall it off. So sometimes what happens is the person isn't able to kill the bacteria with their own immune system, but their immune system can create sort of a barrier around the actual infection. So this is my chest x-ray. It's a very bad picture of someone's lungs and there's their heart. That's my chest x-ray. I might have had a TB infection that my own immune system worked to wall off. And so I don't currently have symptoms of tuberculosis because my immune system has successfully kind of put it in a little room to isolate it. But that could get reactivated. So having this lesion here that's tuberculosis infection that's called latent in that it's not active. I don't have the symptoms, but it's there and could reactivate, puts me at risk of developing an active tuberculosis infection, such that if I became immunocompromised or really, really sick and my immune system couldn't keep that wall up around that infection, then it could become awake and active. Or I could have active treatment. So that's the two types of infections I might have to tuberculosis. I could have an active infection where the tuberculosis mycobacteria are actively dividing and causing changes, damaging the inside of my lungs. Or I could have a walled off infection that could become reactivated if I became sick with something else. Either situation, whether it be active or latent, needs to be treated. If I have active tuberculosis, I will be treated for the length of time it takes for that infection to go away. 6 months to a year, potentially. If I have latent tuberculosis, I will be getting treatment for at least 6 to 9 months to be sure that that infection goes away. So it's hard to treat. And I can't just treat it with one drug. I have to treat it with multiple drugs. And so put stars around this because this is always on the test. If the patient is on, it has an active infection, they need to use more than one drug. It's a multi-drug. And the reason is to prevent resistance. So anyone with an active infection is on multiple drug therapy to prevent resistance. Anyone on latent treatment is only on one drug. They just have to take it for a prolonged period of time. So if the patient says, I have active tuberculosis, and I wonder why I have to be on 2 drugs, it's to decrease resistance. And these are the drugs that we use. So first of all, does anyone know the symptoms of tuberculosis? How do you know if someone has tuberculosis?
Don't they have a wet, pink-tinged cough, like sputum kind of coming out?
It's usually very productive with sputum, and it tends to be pink or blood tinged because it's the inflammation leads to that. They usually have high fevers, especially at night. Just a frequent sort of almost bloody cough and night sweats. And it can destroy a lot of lung tissue, and so it does have a higher mortality. It can. So it's not something you want to just, let live. You want to get rid of it. If you're doing a TB skin test, you're trying to find the people that might have a latent TB infection. When you're doing the TB skin test, you're putting a tiny amount of that tuberculosis material, tuberculin, that's altered, not to give you an infection, but just to see if your body has ever been in contact with tuberculosis. And if it does, it's going to have that hyperimmune response, this time on your skin. So then you'll see the red area that's swollen and indurated. You can feel it. The problem with that is sometimes that'll be positive, and the person might not have a latent infection. Sometimes it's positive if the person's had the tuberculosis vaccine, because there is a vaccine, especially if people didn't grow up in the United States and grew up in Asia, since tuberculosis is more of an endemic infection, people are vaccinated against it, whereas we're not here. So they'll always be positive. Sometimes people will have a latent infection but will not show that they have a positive tuberculin response, depending on their immune function. So even though I'm not sure if they still require TB skin tests for you guys, but the more accurate way to test for it is to do the blood test to see the quantiferon gold test to see if there's tuberculosis present. So these are my treatment options. You had to do the skin test. I know it's kind of dumb because it's really not the best way. I'm sure it's cheaper. So isoniazid is a medication that can be used for both active and latent TB. If it's for active tuberculosis infection, it'll be paired with one of these other drugs. If it's for latent tuberculosis infection, it'll just be by itself. So that one is the most important one. We will talk about isoniazid and rifampin as our main medications to treat tuberculosis. These other drugs are listed in ATI, but the information is primarily on isoniazid and rifampin, so that's what we will focus on. Isoniazid, like I said, can be given by itself or with another drug for active disease. It's oral or IM. It should be separated from meals if able, and antacids. This is another medication that has that disulfiram reaction, just like metronidazole, sulfametholazole, like cephalosporins. Those medications that are similar enough to alcohol can make the person feel sick. There is a risk, which is another reason to avoid alcohol with this medication. You'll see that all of the adverse effects could be potentially increased by alcohol use. So hepatotoxicity, we talked about that being abdominal pain, yellowing of the skin and eyes, dark urine, whiter, lighter colored stools, the elevation in AST, ALT, and bilirubin. Which obviously the alcohol is hard on the liver too, so we want to avoid alcohol for sure. Anyone who drinks alcohol is at risk for peripheral neuropathy. Does anyone know what peripheral neuropathy is? I know there's only
loss of feelings or tingling, like kind of loss of feeling at the end of your fingers.
Right. It usually occurs in the hands, although it can occur in the feet too. But it's like a paresthesia, numbness or tingling or lack of sensation in the hands and feet especially. And the other effect could be seizures or psychosis, meaning the patient is kind of crazy. All of those things increase if the patient is drinking. And there does tend to be an increased risk of active tuberculosis infections in the alcoholic population. I don't know if it's just exposure, increase in exposure to tuberculosis, but that tends to be the issue. So we have to watch for these symptoms very closely because they're going to be at risk for that. Rifampin is used as part of the active tuberculosis treatment. It also can be used for other infections, but we're just going to talk about it in terms of active treatment of tuberculosis. This should also be separated from meals. It can also cause GI complaints and also lead to liver toxicity. So that's just like isoniazid. So we have to be very careful. The other, oops, that's not what I want to open. The other thing it can do is that it can change your body fluids to a reddish orangish color. And it's not harmful, it's just weird. And so you want to be sure that patients notice this and they might need to make some changes. So that means your tears, your sweat, your urine, even your stool. So a patient wears contacts, they can't wear contacts while they're on this therapy or their contacts will be stained. They shouldn't use white sheets because their sheets will be stained, from sweating in their sleep. Their urine will be this weird orange color, and that's normal. It'll go away after they stop the treatment. It doesn't mean they're bleeding. That's what you have to reassure people what that means. And anyone on tuberculosis medications has the potential to have this drug reaction with eosinophilia, which ends up causing the severe facial swelling and potential inflammation of other organs. So this is a different type of fever, rash, skin reaction to medications used for tuberculosis, in which the patient gets, the key is facial swelling from it. So they would actually have to stop the treatment, which would be difficult because there's not a lot of options. So we'll stop there. Next class, remember the quiz is on the first set of slides. We will finish, we will do the study sheets that I was talking about, and we'll finish infections, and we'll move on to especially immunotherapy. We might have to, we'll see what we can all fit in the next class. So any questions about what is due or what's coming up? I have to grade your community pharmacy projects. I will go back over the exams to be sure that I've graded all the short answers correctly. I haven't looked at my email yet, but if you want to make an appointment to discuss the exam or to screen share and look it over together, that is fine. What was your question, Hannah?
I was just a little bit confused on the second part one. We were supposed to because what I did and how I interpreted it is that I made like a MAR of the medications of like my patient that I had and did the 4-5 medications on. And I kind of just took them at the times and kind of like administered the medications to myself. Is that what we were supposed to do?
Right, and then you were supposed to, the point of the project is for you to see how difficult it is to follow a schedule if there's multiple medications.
Yeah, okay, good, because that's what I was just making sure that I did it right.
Yes, that sounds right.
Okay, thank you.
Sure, especially if you have to take something more than once a day, people usually forget, especially in the beginning. It's supposed to be more empathetic to the patient's struggle.
Okay, good. That's exactly
right.
Thought it was. Okay, good.
Okay, good.
Okay.
Yeah.
Thank you.
Like, sure, no problem. Hannah or Natalie is. Can we have more times where you eat M&Ms? No, but you're fine to eat M&Ms, except when we talk about diabetes, you might start to feel bad about that. So that's it, guys. Anyway, you can email me if you need something. Devin, I highly recommend that you listen to the beginning of the class. You might find it kind of funny because we seriously did call you out. All right, take care, guys.